Regarding the primary outcome of functional independence, all the clinical trials show benefit for those that were treated with endovascular therapy. That benefit, if we summarize it, reduced significantly the amount of patients that were dependent at 90 days from the initial treatment. That was significantly better than in those patients that receive only medical management. The secondary or the additional outcome that was also measured of independent ambulation was even more notoriously different in favor of those patients that receive endovascular treatment, with almost 36% of them being able to deambulate independently compared with 19% in the medical arm. Regarding the complications, symptomatic hemorrhages were seen in different degrees in the different clinical trials. In 4 of them, they were nominally lower. In 2 of them, they were nominally higher in the endovascular group compared with the medical management group. However, this didn't reach any statistical significance. In terms of mortality, most of the trials show benefit in reducing the mortality of these patients at 90 days. In summary, the results of these 6 clinical trials are very positive for the application of endovascular thrombectomy in patients with large core stroke. The improvement in functional independence was significant, with a functional independence of 19.5% in patients that went to endovascular treatment to a combined comparison of only 7.9% in those patients that receive medical management alone. However, it's important to notice that this functional independence is still limited. Only 20% roughly of the patients reached that level. There was a little bit of a bigger impact in the ability of these patients to walk. But still, patients with large core stroke have significant morbidity that needs to be considered. It is clear that these trials show the benefit of the endovascular therapy, with a calculated necessary number to treat, or number needed to treat, of 8 to prevent 1 patient from getting a functional dependency. However, it's also important to observe the differences in the clinical trials and some specific aspects of the populations that were included, because that can impose some limits in the generalizability of that data. For example, age was one of the main constraints. Most of the patients that were enrolled in these trials were generally younger patients, and there was a limited number of those that exceeded 85 years of age. In particular, in those cases, many of them were treated only early or with a specific imaging criteria to be sure that there was not flare abnormalities or that the core was not as big as a 0 to 2. A second factor that is important to consider is the level of pre-stroke disability. Consistently, all the clinical trials, including patients that have modified ranking scales of 0 to 1 in their inclusion criteria. There was one that was slightly more liberal to 2, but the large majority of patients were functionally independent before being included for treatment.